Welcome to the clinic. Today, you're not just watching medicine, you're practicing it. We have 5 patients, 5 mysteries, and 5 lives waiting for your expertise. From heart rhythm puzzles to diagnostic dilemmas, you'll work through the history, exam, and data, then commit to your diagnosis before the reveal. Here's the rhythm. We begin with the history, where the answers usually hide. Next, the exam findings. Then the investigations. The most crucial part? You decide. I'll pause, you commit to your diagnosis, and then we'll review the reveal and the clinical pearls. Let's start with our first patient. Here is today's case board. 5 patients, ranging from heart rhythm issues and chest pain to chronic cough and abdominal distress. 2 hearts, 2 sets of lungs, and 1 abdomen. Keep your notes ready. Your first patient is already waiting for us. Case 1. A 75-year-old man presents with 6 months of dizzy spells, falls, and blackouts. He's arrived in the emergency department feeling unwell after his latest episode. As we dive into his history, search for the key details that set this apart from a routine faint. The pattern is concerning. Recurrent blackouts over 6 months, often linked to exertion. A witness described him as turning deathly pale and motionless. While his initial workup at the hospital was unremarkable, his symptoms persist. No alcohol history, no chest pain, and no palpitations. Take note of that pallor. The examination provides a critical clue. His pulse is steady but very slow at 33 beats per minute. His blood pressure is on the lower side, and he remains pale. Also, look at those jugular veins. There are occasional sharp, sudden rises. This heart rate is a major red flag. Look at the tracing. The P waves are steady at 75 per minute, but the QRS complexes, which drive the ventricles, are only occurring at 33 per minute. They are entirely uncoupled. This electrical disconnect is the key to his condition. It is decision time. First, identify the rhythm on this tracing. Second, explain why he blackouts and why his previous ECGs might have appeared normal. Think about the clues, the pulse rate, the pallor, and the uncoupled electrical activity. Pause the video and commit to your diagnosis now. This is complete or third-degree heart block. The atria and ventricles are electrically disconnected. His blackouts are Stokes-Adams attacks caused by transient loss of cardiac output. A normal ECG between episodes doesn't exclude this. His fixed, slow rate is dangerous and requires urgent intervention. To wrap up case 1, remember the bedside clues. Those sharp neck vein rises are Canon A waves, a hallmark of heart block. Always value the witness account when evaluating blackouts. It can be more informative than any scan. Finally, remember that normal conduction cannot be ruled out by a single normal ECG. The definitive treatment for complete heart block is a permanent pacemaker, preferably a dual-chamber system. If you are ever unsure about the patient's stability, initiate temporary pacing immediately. These are the key lessons to carry forward into your next cases. Case 2. A 34-year-old man presents with 4 hours of central chest pain. We must accurately distinguish between high-risk conditions and less severe ones. One specific detail in his history will be your guide. Let's look at the facts. Our patient has central chest pain that improves when he leans forward and worsens when lying back. He reports a recent head cold, and while his family history mentions a heart attack, he is young and healthy. Focus on that positional nature of the pain. On examination, he has a low-grade fever, but his heart and lungs sound normal. Lab results show a raised inflammation marker, the ESR, and a slightly elevated troponin. We have an inflamed clinical picture with a hint of heart muscle involvement. The ECG will be decisive. This tracing shows street segment elevation. Compare the shape. Is it concave, resembling a saddle, or convex, like a dome? The concave, widespread elevation is characteristic of this condition. Use this clue, along with his history and the lab findings, to make your final call. Pause the video and commit. Question 1. What is your diagnosis? Question 2. How do you explain the fever, raised ESR, and that slightly raised troponin in this patient? Your clues include his postural pain, a recent head cold, and widespread concave ST elevation. Use these to piece together the answer. The diagnosis is acute pericarditis, likely viral. It's inflammation of the heart's outer sac, explaining his fever and inflammatory labs. The ST elevation is concave and widespread, not territorial. That slight troponin rise? A bit of adjacent heart muscle is inflamed, myopericarditis, but it's not a heart attack. 3 things sharp clinicians know. First, a friction rub is often absent. Keep listening. Second, Echo and troponin help size up any myocarditis. Third, viruses aren't the only cause. Always consider post-infarct immune reactions, autoimmune disease, or other systemic issues when the clinical picture suggests it. Our patient recovered well with rest and NSAIDs. Remember these pearls. Concave ST elevation points to pericarditis, not infarction. A viral prodrome in a young person makes pericarditis a top suspect. Finally, treat the whole clinical picture, not just the ECG. Case 3. A 19-year-old with a lifetime of respiratory trouble. Frequent infections, years of missed school, and now a sputum report that has his mother worried. When a respiratory history spans an entire life, you aren't looking for an infection he caught. You're looking for one he was born with. His history begins in early childhood with recurrent bronchitis. It's a persistent, lifelong pattern. He's thin, reports irregular bowel habits, and has no family history of lung disease. Remember, a lifelong respiratory history in a young adult is a red flag for a congenital condition. The examination confirms he is underweight. His chest sounds have crackles, and the X-ray reveals damage in the upper lobes with dilated airways or bronchiectasis. This structural damage keeps him trapped in a cycle of pooling secretions and repeated infections. It's time to analyze the microbiology. His sputum culture history shows a shift from Haemophilus to Pseudomonas, which is now persistent. Pause the video. What is the diagnosis? And why do the upper lobe findings, the bowel issues, and the chronic Pseudomonas all point to the same systemic condition? The diagnosis is cystic fibrosis. It's a genetic defect affecting chloride transport, causing thick, sticky secretions that damage both the lungs and the pancreas. The upper lobes are characteristically affected, and Pseudomonas eventually colonizes these damaged airways. Pancreatic issues explain his thin frame and bowel habits. Confirmation involves a sweat test for high sodium and chloride levels, or a nasal potential difference test in specialized centers. Genetics can identify the defect, while high-resolution CT provides the definitive map of airway damage. Don't be fooled by a negative gene panel in milder, late-presenting cases. This is a whole-body disease. Beyond the lungs, consider the impact on the pancreas, sinuses, and liver. Differential diagnoses for this clinical profile include antibody deficiencies or cilia syndromes. Always assess lung function to help grade the severity of his impairment. Management requires an experienced specialist team to optimize outcomes. Treatment is focused on managing, not eradicating, Pseudomonas and preserving lung function. In severe cases, transplant is an option, and new gene-based therapies are evolving. Remember, upper lobe bronchiectasis with Pseudomonas is a classic signature. Case 4. A 26-year-old teacher. 3 months of persistent cough and antibiotics have failed. Her story is defined by specific triggers and timing. In this next part, we'll see how pattern recognition and simple home measurements reveal the truth. Her cough is worse at night, triggered by cold air and exercise. She has a history of childhood bronchitis and a family history of allergies. These are all classic red flags for an underlying airway condition. Despite her symptoms, her clinical examination remains normal. Clinic tests were normal, but home peak flow monitoring revealed the answer, a clear diurnal variation. Her airways are tight in the morning and loosen by evening. That pattern is the diagnostic key. Based on these findings and her history, what is your diagnosis? Pause the video and make your call. Question 1. What's the likely diagnosis behind this 3-month cough? And, as a bonus, why was amoxicillin never going to work? Question 2. How would you confirm the diagnosis given that her spirometry in clinic is completely normal? Your clues: the trigger trio of nighttime, cold air, and exercise, a childhood labeled recurrent bronchitis, a brother with hay fever, and a home peak flow chart where evenings consistently beat mornings. Commit to your answer. The reveal is next. The answer: asthma, specifically cough variant asthma. Her 8% diurnal variation is suspicious but not diagnostic, and that's an important lesson. Suspicious numbers don't end a workup, they earn a better test. Everything else fits, and because a persistent cough with a normal exam is rarely bacterial, those antibiotics never had a chance. Confirmation came from a provocation test. After 6 minutes of vigorous exercise, her FEV1 fell by 25%. That's diagnostic. The logic is simple. If you suspect twitchy airways, provoke them and measure. And for a persistent cough with a normal chest X-ray in a non-smoker, think of the rule of 3. Asthma, postnasal drip, or reflux. Her treatment became an accidental proof. An inhaled steroid settled the cough within a week. When she stopped it, the symptoms returned with a vengeance. Restarting the maintenance therapy regained control. If control ever slips, check inhaler technique and adherence first, then consider adding a long-acting bronchodilator. Remember 3 things. First, the 50/25/20ths rule covers most chronic coughs. Second, asthma can be a cough long before it's a wheeze. If the spirometry is normal but the suspicion is real, you must provoke and measure. Third, stop repeating antibiotics for a normal exam cough. You're treating frustration, not a bacterial infection. Our final case. A 56-year-old woman arrives in the emergency department. For 24 hours, a constant pain in her upper abdomen has been building, boring through to her back. She feels sick, alternating between hot flushes and chills. The abdomen is a complex puzzle, but your history and lab results hold the key. Her history: constant, climbing epigastric pain radiating to the back, nausea, hot and cold spells, and a history of a duodenal ulcer years ago. She smokes and drinks socially, and her weight is 115 kilograms. Constant pain that bores to the back in a middle-aged patient is a serious red flag. She is febrile at 38.5 Celsius, tachycardic at 108 beats per minute, and dehydrated. Her abdomen shows tenderness in the right upper quadrant and epigastrium, with clear guarding and rebound tenderness. Those signs indicate that the peritoneum is irritated. This is not a patient for wait and see. Let's check the lab results. The white cell count is 19.8, and the CRP is a massive 256. Her liver enzymes show mild irritation, but no major obstruction. Most importantly, the plain abdominal X-ray is normal. This reassures you not at all, as most gallstones are invisible on plain films. It is time to name the diagnosis. Pause the video and commit. What is your diagnosis? What are your first management moves? And which dangerous mimics must you exclude? Look at the fever, the guarding, and that dramatic CRP. You need a diagnosis that explains this firestorm. Think clearly, because the next step in the emergency department is critical. The diagnosis is acute cholecystitis. A gallstone has impacted in the cystic duct, leading to inflammation and bacterial colonization. The classic profile is an overweight, middle-aged woman after a fatty meal. Prolonged pain and fever are your primary discriminators here. Watch out for complications like perforation or stone migration. Before you commit, exclude the mimics. Amylase or lipase checks for pancreatitis. Blood cultures are vital for a febrile patient. Chest x-rays rule out lower lobe pneumonia or perforated ulcers. Finally, the ultrasound is the gold standard, showing the stone and the thickened wall. Stay diligent. Don't let a mimic derail your workup. The plan: admit under surgery, NPO status, IV fluids, and antibiotics. Re-examine regularly for peritonitis. Ultimately, she needs a cholecystectomy. Remember, RUQ pain, fever, and a positive Murphy sign point to cholecystitis until proven otherwise. And always check that amylase to ensure it's not pancreatitis. We've covered 5 cases and 5 essential habits of mind. From heart rhythms to chronic cough and acute abdominal crises, the method remains the same: history, examination, targeted testing, and a disciplined approach to ruling out dangerous mimics. Practice these steps, and your diagnostic skills will sharpen with every patient you see. Rounds are complete. You've navigated heart block, pericarditis, cystic fibrosis, asthma, and cholecystitis. Today, you took the lead. Remember, this is for educational purposes, not medical advice. More mysteries are waiting in the next video. Bring your focus and keep learning.